Thank you very much, Zoe. That was fantastic, your presentation. I loved it. Now we have our next speaker, who is going to be Dr. Peter Ott.
Well, I will thank the organizers, the Patients Association, for inviting me. It's a great honor here to be here today and talk about pregnancy in Wilson's disease. See, my name is Peter Ott. I come from Aarhus University Hospital in Denmark, and we take care of all patients from Denmark with Wilson's disease. Not all patients, but all patients with Wilson's disease in Denmark is taken care of by this hospital. So one of my patients that we have known for at least 8 years with Wilson's disease, well treated, came to me a day and told me that now she thought it was a time in her life where it was reasonable to get a child, and she wanted to discuss that with me as her doctor. And she has these very simple questions. Can I become pregnant? Will the pregnancy be successful? Will my treatment affect the fetus? What will happen to my Wilson's disease? Will the child get Wilson's disease? What about breastfeeding? And afterwards, maybe I want to postpone the next baby and use contraception. I cannot do that. So we sat down and tried to talk through these many questions. The first question, can I become pregnant, was kind of easy to answer, because the answer is yes. We have sufficient data to say that patients with Wilson's disease have an almost normal ability to get pregnant. Probably it is normal, but we need more data which are being collected at the moment in large databases that are being constructed all over Europe. But the answer to her question was yes, she can become pregnant. Will the pregnancy be successful? Will I get a healthy child? And there are several things to consider here. First is, what is the risk of spontaneous abortion? That was studied in this study here. It's a German study by a guy called Pfeifenberger, and he collected data from 282 pregnancies in 136 women with Wilson's disease. And what you can see here is that if the pregnancy is before Wilson's disease is diagnosed, then there's a high rate of spontaneous abortions. But if it is diagnosed after, if the pregnancy is after the diagnosis of Wilson's disease, there is a much lower rate of spontaneous abortion. And the difference is, of course, that these women were treated for their Wilson's disease. And so the treatment reduces the risk of spontaneous abortion. And if we compare with the normal range I have here, in the normal population, there are also spontaneous abortions at a rate of 9 to 17%. So this rate is maybe the risk of spontaneous abortion in a well-treated woman with Wilson's disease is close to normal, maybe a little elevated. Will the risk of a spontaneous abortion depend on the treatment then? And what you can see here, this is data, again, from the German study, and the risk of abortion is related to whether the treatment was penicillamine, triantine, zinc, or combination. And you can see all these groups have the C, spontaneous abortions, but it's probably within the normal range. Here you can see there's a somewhat higher risk in those who were treated with triantine, but there were only very few, so this can well be what we call a statistical mistake, because statistics is only certain when you have large numbers. What we can say with certainty is that this group that actually stopped the treatment during the pregnancy had a very high rate of spontaneous abortion. So this is just to remind you that you can be pregnant, you can deliver a healthy child, return to that, but please never stop your treatment during pregnancy. Never, never. Has spontaneous abortion related to the presentation, to the type of Wilson's disease? And there is some relation. You can see here that patients with severe neurologic disease have a higher rate of spontaneous abortions. And that is, of course, a sad thing, but note that this is 40%, so there's still a considerable chance of getting a child. Patients with severe liver disease, with cirrhosis and even advanced cirrhosis, should talk with their doctor before they get pregnant, because some of these patients, pregnancy is not only dangerous for the child, but also for the mother. So this is a special group. Fortunately, it's only quite few patients, but they will have to discuss what to do with their doctor before they take any decisions, I would advise. Will she get a healthy child? You know, there's a risk. There could be a concern about what we call birth defects. That's imperfections of any kind. And here I combined a number of studies and calculate the risk of birth defects. For example, patients, 169 of these patients were on penicillamine, and 4 of these deliveries, you could find birth defects. These may not be very severe. But there are birth defects. You know, there are also birth defects when non-Wilsonian women have children. I mean, normal population, you also see birth defects. So when you calculate here, the chance of getting a healthy child if you have Wilson's disease is actually 97.5%. So that is a very good chance. In the normal population, it's 98%. So it is very close to normal and probably, in fact, normal. So there are many good messages here. Let's see if I can. Practical normal. We have these databases and we will get more data in the future. So what about stopping the treatment during pregnancy. I already showed you that you shouldn't do it because there was increased risk of spontaneous abortion. Nevertheless, some patients did it, and you can see these are early reports, and there's an increased risk of spontaneous abortion, but there's also even an increased risk of the death of the child and the death of the mother. So this is a very serious condition here, and I have to repeat what I said before. Never stop your treatment during pregnancy. Okay, she said, what about reducing it? But maybe I should take a little less. And that could make some sense. Let's see. There are several arguments for reducing the treatment during pregnancy. One is what we called teratogenicity. It means that the treatment somehow harms the fetus. And see, it may be difficult to read here, but actually when we look at mothers with Wilson's disease who delivers babies, we just saw that there are not more birth defects in these children than in normal children. So it doesn't seem to be a problem. And the reason people are concerned about it are some old data where patients got much higher doses and were treated for other diseases. So teratogenicity is a theoretical problem, but may not be an actual problem. What about copper deficiency? That has also been a concern, but the fact is that no one has ever seen a pregnant woman with Wilson's disease who developed copper deficiency. So that is not an issue either. Should we reduce dose to improve wound healing? I mean, that could be a need for operations during the pregnancy, and wound healing is, of course, important. And that is still discussed. It may be important. It may also not be so important. The concern was raised by the studies on experimental animals, but here I think it's difficult to read, but that is a study where patients were operated in the leg, and some of them were on penicillamine, and there was really no effect on wound healing. So it's perhaps not such a serious matter here. And the last concern is it necessary to have a full dose because the fetus, the child in the woman, is taking up copper to grow. So is that a kind of treatment, of nature's own treatment of Wilson's disease? And it does take up copper, and here you can see this is the weight of the fetus, and this is the uptake of copper, and altogether the fetus takes up 12 milligrams of copper. But if we calculate that, it's less than a tenth of a milligram per day, which can compare with the normal uptake or the normal food content of copper, which is 2 milligrams per day, and the normal uptake from the food is 1 milligram per day. So just to give you some idea that this, even though the fetus takes up some copper from the mother, it's not so much that it really should affect treatment. Altogether, current guidelines advise that we reduce the dose of penicillamine and trientine. Penicillamine and trientine with 25 to 50% during the whole pregnancy, but then increase the monitoring to make sure that we still have a sufficient dose. In those who are on zinc, the recommendation is unchanged dose for the whole pregnancy. So, of course, also want to know what will happen with my Wilson's disease during the pregnancy. And again, the German paper here, the German study, is the largest. They looked at almost 200 pregnancies, and there were 14 cases where liver enzymes, transaminases, increased a little, but it returned to normal values after delivery. So we can say with great certainty that your Wilson's disease will not be affected by the pregnancy. So it's a safe thing also for the mother. Okay, yeah. So the pregnancy will not affect your Wilson's disease if you are unstable on treatment. Will the child get Wilson's disease? And that if the father is unrelated, so it's not a cousin or other member of the same family as the mother, the risk is 0.5%. That is 1 in 200. So therefore, the doctor will help you make sure that you examine the child. Usually, I think it's at 3 years of old first time to make sure that the child does not have it. However, if the marriage is, for example, a first cousin marriage, that is that you in near family, then the risk that the child has Wilson's disease is somewhat higher, and as a consequence, of course, you will examine these children and make sure they be treated before any symptoms arise, and then you know life is pretty normal even with Wilson's disease. So what about breastfeeding? Can I breastfeed my child? She would ask. And there are several concerns here. One is, will the child get too much copper or too little copper? And here you can see a study where they measured first in blood copper, and you can see blood copper this is a normal, and these are patients with Wilson's disease. And then they measured the copper in the milk, and you can see somehow nature repairs the whole thing for the child and compensates, so the child gets exactly the same amount of copper whether the mother has Wilson's disease. So the milk is okay here, and this is zinc, and of course a patients who are on zinc may have a little higher zinc in the milk, but that doesn't seem to harm the baby at all. This is a small study, but it is the largest study that we have. And importantly, they also try to look for the medicines, the medications in the milk. And especially they looked for triantine and penicillamine, and they could not find it in the milk. So it appears that the drug is not transferred to the milk, so the baby is not getting drugs that we don't want them to get. Now, what is the result of this? If we have a dilemma here, because if you go to the guidelines, they will have a safety first point of view. So they say, never breastfeed. And that is the situation with many diseases and with many treatments. As a safety first point of view, they say, don't breastfeed. But as I just showed you, that doesn't seem to be a realistic concern about it. So maybe it's perfectly safe. And actually there is something called a breastfeeding database where they so far have 3 studies with 57 deliveries where patients with Wilson's disease breastfed their babies and there were no obvious problems. So what I think you should do is to take a serious conversation with your doctor if you want to be pregnant and take your own decision. And of course, we are looking forward to more data and we hope they come very soon. Maybe she wants to postpone the next baby. And so what about birth control? Again, the guidelines just advise against as a matter of safety first. As concerns the pills with estrogen are not recommended, and it is known that estrogen interferes with copper metabolism, and I think it's still wise to try to avoid these. However, the mini pill, which is based on progesterone, are probably safe. And these are the 3rd or 4th generation, I can't remember. But so I think the mini pill will be safe. What about the IUD? It's called the DIU, I can see in Spanish. They contain copper and release copper, and that is the way they work. But if you calculate on, they release so little copper that it shouldn't matter anyhow. So even though the guidelines again advise against their use, I cannot see the reason for it. So and of course there are also hormone IDUs that are based on progestin that should. So both of these methods should be safe. So what I have told you now is that pregnancy in Wilson's disease is perfectly possible. It is enormously important that you discuss with your doctor in advance, if possible, not always, but sometimes. Slightly increased risk of abortion, especially in advanced disease. The risk of birth defects is almost normal, can always be said the opposite way. The chance of getting a normal baby is almost normal. Never stop therapy completely. Discuss dose reductions with your Wilson's disease doctor. Breastfeeding is most likely safe. And oral contraception has been advised against, but may be unjustified, so maybe you can use it. And IUD should be safe. And so I will thank you for your attention.